individuals and for businesses, and how it relates to everyday people getting coverage for health care. In the United States, I think there are a few people who wouldn't agree that we have pretty darn good health care. That when you're sick, there's no place in the world you'd rather be, because we do a great job of fixing you when you're broke. There's no question about that. We do a less terrific job at taking care of people when they're well and financing health care. So much of the Affordable Care Act was about financing health care and the mechanisms for caring for people through health insurance. The Affordable Care Act was fundamentally designed to reduce the growth of health care costs in the United States. As you'll see in a moment, the United States spends more money than any other industrial nation on earth per capita on health care. Unfortunately, we get poorer results. We're going to talk about that in just a second. But what we have seen over the years, as all of you know, is we've seen skyrocketing costs of health care. And the Affordable Care Act, in part, was meant to help us begin to reduce the amount that health care costs grow on an annual basis. Nobody really fundamentally believes that we're going to be able to reduce entirely the growth of the cost of health care because of the aging population and other societal factors that simply resist change in that way. The Affordable Care Act was designed to provide Americans access to affordable health care insurance, to strengthen and protect Medicare and Medicaid, and there are elements in the bill that do exactly that, and then to begin to take steps to modernize our health care system, how we deliver care, how we pay for care. For example, a big focus of the Affordable Care Act is to move from paying for volume. In other words, we as healthcare providers, hospitals and doctors, get paid for whatever we do to you. That's just the way it is today. If you come in and we do something to you, or I think my staff prefers I say for you, we get paid for that. In the future, what the Affordable Care Act provides for is that we are going to be much more gauged and much more paid on the basis of value. How did what we did for you make a difference in your life? What were the outcomes? Were you readmitted 2 weeks later? Did we give you an infection while you were in the hospital? Today, if we do, you pay for that, or your insurance company pays for us to correct a mistake that was made in a hospital. That will not continue under the Affordable Care Act. So there are some very good things in the Act that are designed to help streamline the system, to encourage higher quality throughout the healthcare system, and really to protect patients and their families. This is the slide that I was talking about in terms of U.S. spending on healthcare each year per capita. And it shows you how we compare at $8,000 per capita to the other countries that are shown here. And we could have added Germany, we could have added 10 or 15 other industrialized nations, all of which have lower health care costs than we do, and all of which have better health outcomes than we do. Their people are living longer, they have lower infant mortality, and they have significantly increased their ability to keep people healthy. The reason that is that a good portion of the healthcare dollar that they invest under universal health care programs in those countries is invested on wellness and prevention. Keeping people well before they get sick is frankly a lot less expensive than it is fixing people when they're broke. It just makes good sense. The Affordable Care Act is like a huge jigsaw puzzle. And I think that's something we all need to keep in mind, because as legislatures continue to tinker with the Act, you have to remember that if one piece of the Act falls, the rest are harder to keep together. Okay? So that everything we're going to talk about today, it's important that it be enacted in total. Under the basics as it relates to coverage for individuals and businesses, there is something called the individual mandate, which provides that all individuals must procure or otherwise purchase health care insurance or pay a penalty. We're going to talk about what those penalties are in just a few minutes. It also provides that businesses with 50 or more full-time equivalent employees either provide affordable and health insurance, or they pay a fine if one of their employees goes to the exchange, gets insurance, and is provided with a tax credit or subsidy. That's an important differentiation because, for example, if one of my employees, say I employ 160 employees, I provide health insurance and they elect to not take my insurance, go out to the exchange and purchase health care insurance, and they make $50,000 a year or more, they're not going to receive a tax credit and I'm not going to be fined. So there are some very specific rules that apply to businesses who provide insurance for their employees. Do we have any small business people here, small business owners? Okay, we're not going to spend any time on that tonight then, okay? We'll just kind of blow through the business side of things and spend more time talking about the individual mandate. The expanded insurance is being provided, as you probably know, through health insurance exchanges at the state level and at the federal level, and then the expansion of Medicaid. Now, if you recall, when the Supreme Court indicated that the Affordable Care Act was legal and it was enacted and confirmed into law, what they said about the expansion of Medicaid is that the federal government could not mandate that states expand their Medicaid program. So that was going to be optional. That is a problem for states who have said they are not going to expand Medicaid. Number one, it limits how people can get health insurance and leaves a lot of people who would otherwise be able to qualify for insurance unable to get it. Secondarily, it's detrimental to hospitals because this is one of those jigsaw puzzle pieces that I was talking about earlier. In the Affordable Care Act, one of the cost containment strategies that hospitals, again, hospitals were at the table when the Affordable Care Act was designed. One of the things that they agreed to is if you're going to bring more people to the table with insurance, whether it's Medicaid or whether it's commercial insurance, then you, federal government, can reduce a special payment that's given to hospitals that treat a high proportion of uninsured patients. That's called a disproportionate share payment. Part of the Affordable Care Act says if we're going to insure more people, then we can reduce those payments to hospitals. Okay, so it makes sense. If one thing happens, then we can do the other. In those states where Medicaid is not being expanded and hospitals are being hit with a decline in that payment, it's kind of a double whammy for those hospitals. So that's one of those jigsaw puzzle pieces that need to fit together to make the whole thing work. I think we'll just go through these really quickly because I'm sure many of you are aware of these, that in 2010 when the law was enacted, there were many things that went into effect. No lifetime limits on what insurance companies pay for in terms of coverage for their individual members. There are restricted annual limits on payments. They can no longer deny based on a threshold, an arbitrary threshold that they have determined is appropriate. There are restrictions now on rescission of coverage. In other words, you've been paying for insurance for 10, 15 years and all of a sudden you get sick and they say, oh, by the way, we're not going to cover that. So there are very severe restrictions placed on insurance companies so that they can no longer behave in these ways. There is also something called first dollar coverage for preventative services. And remember when I said other industrialized nations spend more time and more money and resources on keeping people well? This is aimed at doing that. For the first time, our national Medicare, Medicaid, and others now are required to cover preventative services for first dollar. In other words, there's no deductible or copay applied to those services. So that's a very good thing for people. It encourages people to go get that annual physical, to get that screening, to get that checkup. There is extended dependent care coverage. Most of us who have children under the age of 26 realize that until they're 26 years old, we can now keep them on the family policy. And then there's no pre-existing condition exclusion for children. That's what was in effect in 2010. As of 2014, that pre-existing condition exclusion is expanded to the entire population, so that you cannot be turned down by an insurer if you come to them with cancer, with a heart problem, diabetes. There's also something in the law that says insurance companies must now defend any future increases. There cannot be arbitrary increases in insurance premiums without justification. These are in effect as of January 1, 2014. As I said, the first and foremost, most important one is you cannot be excluded from participation based on a pre-existing condition. There are limitations placed on insurance companies in terms of how they determine rates on a state-by-state basis. There are also something called required separate statewide risk pools. In other words, so that we're looking at a reasonable geographic area for determining insurance rates both on the individual market as well as in the group or small business market. And then there are limitations on out-of-pocket costs, including deductibles and co-payments that are not to exceed $6,350 for an individual and $12,700 for a family. Now, for existing insurance plans for businesses that provide insurance plans today, this has been delayed along with the implementation of the business mandate until 2015. But for those people getting insurance coverage on the exchange, these limits will be in effect. So again, it's a very good thing because it's what we're trying to do is reduce that out-of-pocket burden for individuals who purchase on the exchange. So, what is the individual mandate? It's exactly that. It is what's going to make the whole thing work. Because what it says is to the insurance companies, what's in it for the insurance company if all people can't buy insurance or aren't mandated to buy insurance?
Sick people.
All they get is sick people, exactly right. So from an insurance company standpoint, this is a good thing because they get a healthy population coming into their insurance pool. Persons without employer-sponsored health insurance, Medicare, Medicaid, or other public coverage like the VA will be required to purchase health insurance. Remember, as I said, either through expanded Medicaid or through a health insurance exchange. There are some exemptions. If you cannot purchase insurance for less than 8% of your annual income, you'll be exempted. Persons in healthcare sharing ministries are exempted. Native Americans are exempted. Undocumented immigrants are not covered by the Affordable Care Act. People in jail don't have to buy health insurance. If there is a financial hardship, and there is a whole list of qualifications for defining financial hardship, they will be granted an exemption through Health and Human Services. And then certain faith groups will also be exempted if their religious beliefs prohibit insurance. I understand there's a whole bunch of churches now that are scrambling. No, I'm just kidding. Ignore that.
Does that mean that whole group won't have insurance?
They are not going to be required to have insurance, these people who are exempted. They can still buy it if they want it, but they will not be penalized if they do not.
Is the
Yes.
penalty still $2,000?
I'm sorry?
Is the penalty still $2,000?
No, it was never $2,000. I'm going to give you the specifics on the penalty in just a few minutes, but the minimum penalty is the first year $95 or 1% of your income. Okay. So, and then it goes up year 2 and year 3. So we'll talk about that in just a second. Also, if your income falls below the threshold for filing income tax, you're exempted because the way they're going to check to see if you have insurance is through the filing of your income tax beginning in 2014. When you are insured, either through your broker, as you do now, or through Medicare, or through the insurance exchange, or through Medicaid, you will get an insurance certificate that must be filed with your income taxes. So that's the way they're going to be able to check. Okay. The IRS just came out with rules that I'm still wading through. to figure that out. So I wish I could tell you more about that, but as soon as I know, you'll know. So these are the penalties. For an adult, it's $95 or $47.50 for a child, or 1% of household income in 2014. And then you can see how it grows to 2% and 2.5% by the year 2016. If you earn less than $11,000, they're assessing no penalty because it's assumed that you might not be able to get coverage for less than 8% of $11,000. If it's below $10,000, as I said, you're exempted because that's the threshold for filing income tax.
That's an annual figure?
Annual. Okay, so that you can see, year one is for say a young person, which is the target audience that people are most concerned about. Like my friend Kat Forrester here. She's young, she's right out of school. She's gonna live forever, right? What do we need insurance for? So we've got a lot of education to do with young people to help them understand the benefit of having coverage, especially in the case of a catastrophic event. But you can see then, as the years go on, and depending on your income, the penalty can be quite steep. Massachusetts, as you know, was the first to adopt this model. As of today, they have 98.1% of their population is fully covered through Medicare, Medicaid, or the commercial exchanges. And if you contrast that with the current national rate of uninsured people, it's 15.4%. In Texas, it's something like 20%. So it varies widely state by state. FactCheck.org has said, any way you want to look at it, premium costs went down in Massachusetts based on their state healthcare exchange. And 60% of those buying insurance in Massachusetts for the first time had never had insurance before. So that's kind of a profile of what we might see on a national basis. It's interesting that in those states that are kind of bellwether states, and if you look at California, Oregon, and New York State, they're already way ahead of us in terms of establishing their exchange, getting those insurance companies to participate. They are seeing declining insurance rates. This was something that all the naysayers were saying, oh boy, our rates are going to go through the ceiling. It hasn't shown to be true yet, at least on experience. And you can't read that very well, but in California they went down 29% on the exchanges, and in Oregon they went down 35%. They're estimating that New York State will see reductions of 50%. That strikes me as a big number, so don't take that to the bank, but that's what they're reporting. Okay, I'm from HHS, Health and Human Services, and I'm here to help. How do people access the health insurance exchanges? What's going to be available to help people get insurance? And these are some of the ways that they're doing it, through cost-sharing subsidies or actual tax credits for individuals. Again, this is driven by your individual income. And the threshold for getting a tax credit or a subsidy of any kind is 400% of the federal poverty level, which is currently $11,490 for an individual. That's their income for a year. Okay, so that's the federal poverty level. So you can earn up to 400% of that, calculation something like $45,000, I'm guessing, and still qualify for a tax credit. The way a credit might work is if you had an income of $22,340 and you selected a plan that cost $3,500, your subsidy would be just about 2/3 of that. So that it's an incentive for people to get into the insurance market for those individuals who have less than 400% of the poverty level. Okay? The employer mandate, I put that in quotes because we talked about that before, because it only, it's kind of shifty, I think, shifty wording. Is it a mandate? Is it not a mandate? Employers are only penalized, A, if you have more than 50 employees, and B, if one of your employees goes to the exchange and gets a tax credit. So that's the trigger. And what it's called is it's called a responsibility or a cost sharing support to help defray the cost of the federal government's tax credits for those individuals. Okay. We're not going to spend time on this because none of you are in business for yourselves, but suffice it to say, there are levels of penalties that will be assessed for those employers who don't provide insurance and employees receive a tax credit. Medicaid expansion, what that means is it will now be available, and as you know, or as you may know, this did pass the Senate this week in the state of Michigan, so they have said that they will expand Medicaid for our population. There is a debate about whether it's going to take effect January 1, 2014 or April 2014. The governor, as you may know, is pushing for January 1. The bill is kicked back to the House now. They will vote on it once again. And then it is assumed that if the House accepts the bill just as the Senate sent it over, that we can expect that it will take effect January 1, at the latest April 1, 2014. Again, available for individuals and families, adults aged up to 64, pre-Medicare, and up to 133% of the federal poverty level. Again, that $11,490 a year for an individual. This is optional for the states, so you're going to see across the country, and I think I have a map that shows it, where the states are that are expanding Medicaid and where they are who are not. The interesting thing is that there's been a lot of hue and cry about, oh, the horrible expense that's going to accrue to the states. The feds are planning to pay for this, lowering it only to 90% of the total additional cost after 2020. So 100% for the first 3 years, and then a gradual decline through the year 2020 to 90% of the cost. So on a statewide level, it's a pretty good deal. And I always say if Jan Brewer in Arizona can do it, my goodness, you ought to be able to pull that off in Michigan. So it looks like we have. This is good. The states do maintain flexibility in administering their Medicaid plans in terms of how they define benefits, what kind of cost sharing there is for Medicaid patients, and then also how to deliver and pay for care. It also, some states are being very creative for Medicaid patients and giving them a voucher to go to the insurance exchanges to purchase coverage from the exchanges. So that's a possibility. We don't see that happening in Michigan, but it could. It is happening in other states. The local health departments, our local health departments, and others throughout Michigan are going to be taking the lead and getting people signed up for Medicaid expansion. One of the things that they did see in Massachusetts was even though they got a lot of people covered, which is again a wonderful thing, they still didn't have enough primary care providers to take care of all of the people who are newly insured. That's going to be a nationwide problem because we just don't have enough primary care physicians in our country. So if you look at the state of Massachusetts, again, kind of a bellwether for us, they have more community health centers and free clinics today operating than we do in Michigan, and it's because they don't have a network of primary care providers to take care of the newly insured. So, what's a health insurance exchange? It's also referred to as an insurance marketplace. And the way I like to describe it is I'm a big shopper. I don't know if the rest of you are, but I confess. I'm a big shopper, and I do some of my shopping online. And sometimes when you go to Google, you can type in silver slippers, and bing, up come all these places where you can buy silver slippers. Same kind of concept for the insurance exchange. On the exchange, online, or with an individual, and we're going to talk about who those individuals are in a minute, you will be able to look at the various options that you might have available to you. You can review benefits based on your needs. You can determine if financial assistance is available for you. Once you type in your annual income, up will pop, oh, by the way, you're eligible for a tax credit. So let's talk about what plan you might select and what that credit might look like. You will also be able to estimate your out-of-pocket expenses and compare quality among similar plans. For individuals, it's called the American Health Benefit Exchanges, and in Michigan, it will be what's called a federally facilitated exchange. Michigan is one of the states that has decided they are not going to implement an exchange on their own. They're going to let that fall to the feds. And then for the small businesses, there's called the Small Business Health Options Program. One of the things that the Affordable Care Act said to the insurance companies is there are a list of things, and forgive me for not having my monitor behind here. I've got to change this slide. Will you remind me, Kat, to do that? There are a list of essential health benefits that every plan must cover. These are those. So no matter what insurance plan you pick on the exchange, this is a guaranteed list of benefits that must be there and must be covered for you as an individual. This is also some of the preventive services that now will be covered for all adults. It's a significant number, and as you can see, many of them lean toward screening, lean toward the front end of the healthcare system. How do we keep people well? How do we ensure that all people know their numbers, know what their body mass index is, know what their heart rate is, know what their blood pressure is, know what their cholesterol is? Before, a lot of these things simply were covered. It was out of pocket for people. So many of these things will be covered now and will be good, again, good for the patient and ultimately good for the healthcare system. We have at our hospital, we have a director of community health education and outreach, and she kind of laughingly tells people that it's her job to drive me out of business at the hospital. I'm not amused, but nonetheless, the thought is good. You know, if we can keep people healthy, number one, that reduces cost of the healthcare system instantly. It's better for people, it's better for the system. So lots of investment, lots of upfront talk about more wellness, more prevention in the Affordable Care Act. I wanted to show you real quickly where we were having state public exchanges and federal. This is hard to see, but the very lightest states, including the state of Michigan, are those states that have opted to default to the feds to run their health insurance exchange. That medium gray is what's called a partnership. A partnership between the state and the feds will run the health exchange. And then finally, the darkest states are those that have already established state-based exchanges. And you can see some of those bellwether states, California, Oregon, Washington, New York. They're already kind of ahead of the curve because they said, hey, we'll do it ourselves. And they started running with it. I thought you'd be interested to know that in Michigan, 1,200,000 people are uninsured. Those individuals who do not qualify for Medicare are today uninsured. 1,100,000 of those are less than 400% of the federal poverty level and likely to be eligible for a tax credit. That's a lot of people. A lot of people who would qualify for a tax credit to purchase insurance. About 70,000 are children under the age of 19 and less than 200% of the poverty level, and they're uninsured but currently eligible for Medicaid, so that we haven't gotten them enlisted or enrolled in Medicaid as yet. And then about 500,000 adults aged 18 to 64 who will qualify for Medicaid. Okay, so that really gives you an idea of the volume of people that we're talking about being directly impacted by this implementation. So who can go to the health insurance exchange? Fundamentally, anybody who wants to. Now, if you have insurance today and you're happy as a clam with it, stick with it. It's fine. That doesn't mean you can't shop. You can still go out and look and you can see whether there is a better plan for you as an individual. If you have Medicare, nothing changes for you, except that in the Affordable Care Act there is, and those of us on Medicare know that there's something called the donut hole. If you have prescription insurance, the Affordable Care Act has begun to, I'm sorry, that's me, I should have turned that off. I could dance while it goes on. So other than that, if you're on Medicare, stick with it, you're just fine. You must be a legal resident of the United States to qualify. Again, as I've said, you may qualify for tax subsidies or credits. Again, the most important thing is, and this is one of those things that's out there, I can't tell you how many people, even people who are covered by Medicare, have called and said, Well, now, what do I have to do? When do I have to change? There's no changing about it. If you have insurance that you like, you can stick with it. That's the end of the discussion. You don't have to change. If you don't have insurance, you need to go get it, for sure.
What about the supplemental insurance on Medicare?
Same. You can still, it's still the same. You can still purchase through AARP or United Health. You can always, if you want to, check the exchanges, but for Medicare supplemental, it's probably best to stick with what you have.
And what about Blue Cross's Medicare Advantage?
I don't know what they're going to do with that, to tell you the truth. Because what has happened in the Affordable Care Act with Medicare Advantage is, with the Medicare Advantage program, there used to be a federal subsidy paid to insurers to provide that. That subsidy is being reduced and ultimately eliminated through the Affordable Care Act. So it might change the rates for an Advantage program. I haven't looked at it in detail enough to know. They may not. But I would check with your insurance agent or with Blue Cross to see whether they have a plan. Insurance plans who wanted to be on the exchange have to go through an application process to be approved by the exchange. In Michigan, we have 14 insurers. Again, I'm sorry, this is a little hard to read, but most of the major players will be on the exchange. Alliance Health, Blue Care Network, Blue Cross Blue Shield of Michigan, Consumers Mutual, that's a relatively new insurance plan in Michigan. Health Alliance has largely been in southeastern Michigan, may expand a little bit with this. McLaren Health Plan is generally statewide. Physicians Health Plan has been a southwestern Michigan plan that may again expand its geography. But that gives you an idea of the 14 providers who are going to be in the marketplace for individuals. 13 of those will be for individuals. There is one, United Healthcare Life Insurance Company, is going to be on the exchange only for small businesses.
Will Charlotte Memorial Hospital accept all of those?
Right now, we accept, we're not with Total Healthcare USA, not with United Healthcare Life Insurance. All of the rest we accept, I believe. Can you see some that we don't?
I'm questioning Molina. I don't believe
Molina is a Medicaid plan. It's a Medicaid plan, and I think it's one of the 4 in northern Michigan.
So it's their commercial product
Yes.
that we don't participate.
Right. The commercial we probably do not, but the Medicaid side we would. Okay, now, this is another big fear that's out there that says, oh boy, the Affordable Care Act is going to change my doctor, it's going to make me go to another doctor, it's going to make me go to another hospital. Not true. Not true. Your insurance company negotiates with physicians and with hospitals and other providers. If those hospitals and providers accept your insurance, you can go there. That's how it is today. Or you can go there and pay out of pocket if they don't. So nothing changes as it relates to the Affordable Care Act in terms of those providers and hospitals that you may use. That's one of the things, if you do go to the exchange, that's going to be one of the things that you can enter. You can say, it's really important to me that Dr. Jekyll participates with whatever insurance I take. So then they'll only give you, the choices that they'll give you will only give you plans that Dr. Jekyll will take. Okay? So that's going to be part of the enrollment process when you go to if anybody does in here, go to the health insurance exchange. So, how do you do it? There are lots of vehicles. What they've established is what's called the no wrong door system. So there are going to be individual navigators, there are going to be call centers, there's going to be online chat programs to help you sign up if you do it online, on the online marketplace. There are lots of, and we have one here tonight, traditional insurance brokers that are getting trained up, even as we speak, to help people on the exchange, help them determine what insurance product is going to be right for them. As of September, and we think this is going to be up within the next week or 10 days, the public will be able to go online and play around with it. View the plans that are going to be available. And then October 1st is kind of the go live date where you will be required to sign up. And then the first date that you will be qualified for insurance, or the first date that it will take effect, is going to be January 1, 2014. Open enrollment will continue through March of 2014. Okay? So fundamentally, this is how it works. And it's not all that different from the way you would buy insurance today. You would create an account. If you do it online, or if you do it in the presence of an insurance broker, they're going to take you through a form. They're going to ask you for some information, your social security number, your age, the number of dependents you're going to cover, et cetera, et cetera. You'll create an account. You'll make application starting October 1, and then you'll be able to pick a plan. Again, you'll be able to put in parameters. I'm X years old, I've got X dependents, I want to be sure that I can go to Charlotte Ward Area Hospital. Everybody write that down. Okay? So then up will pop the plans that apply to your needs, and you'll be able to select among them. And then you'll be able to enroll. And again, what they've tried to do is make it as easy as possible. Now I've got to say, with apologies to my insurance broker here, signing up for any kind of insurance is a pain in the neck. I gotta say, it's just awful. I don't understand. They don't string sentences together appropriately. The whole process is to make it as easy as possible. That's the goal with this, and that's why they've invested so much in vehicles to help individuals, and we'll talk about those in just a minute. There are going to be 4 tiers of coverage that people can choose from: bronze, silver, gold, and platinum. And each insurer must offer at least 2 choices, the silver and the gold choice. Now, what's the difference between tiers? A lot of it is going to depend on what your premium cost is going to be, and the premium cost is going to be driven by co-pays, deductibles. So how much you'll pay out of pocket is going to be part of the formula that will help you determine what plan you want to take. Now, for a lot of folks, and I'll give you an example. My sister's COBRA ran out after she left a position, so she went to her broker and said, okay, this is, I'm a healthy person, this is what I need for insurance, and she was steered into a plan that had a $5,000 deductible. Now, again, because they don't string sentences together in a logical way, it didn't register with her that she was out of pocket until that $5,000 deductible was met. So the first time she got hit with a bill, what do you think she said? Holy moly! Yeah, well, those weren't her exact words, but nonetheless, she was not a happy camper. So part of this process is to help educate people about insurance coverage. And yes, a $5,000 deductible will give you a lower monthly premium, but in the final analysis, you got to ask yourself the question, can I afford to write a $5,000 check if I'm hospitalized next week? Okay. There is something called catastrophic only coverage, and this applies to people who are under 30 only, and those that are exempt due to that insurance cost being higher than 8% of their income that I talked about earlier. So for those people only, there will be what's called a catastrophic coverage policy. And that is pretty much like a major medical that really covers you if you get hit by that bus and brought to the emergency room. Excuse me, lots of new pricing regulations in the Affordable Care Act. Some of you, yes,
last
absolutely.
example.
I'm sorry.
You get hit by the bus and are brought to the emergency room and you didn't have a policy, would they still treat you?
Absolutely. Any hospital, any nonprofit hospital that participates with Medicare and Medicaid must accept all comers regardless of your ability to pay, which is why.
So would that person buy the insurance then, or they won't have an
Well,
option?
they'll be encouraged. Everybody has a choice. You can buy insurance or you can pay the penalty. I mean, there is a choice involved here. They will be encouraged to buy insurance. Health care in the United States is unlike any other business, and I'm sure most of you are aware of this. It's not like we're selling toasters here. If you're selling toasters, you know exactly what those toasters cost wholesale, yeah? 50 cents. Cost you another 20 cents to operate your business to sell those toasters. So you mark them $1 and you make 30 cents profit. Here's how it works in healthcare. It costs me $1 to deliver the service. Medicare comes and tells me, if I'm an average hospital, yeah, I'll pay you 60 cents for that toaster. Blue Cross says, I'll pay you 65 cents for that toaster. And so on and so on. Medicare says, I'll give you 35 cents for that toaster, and guess what? You'll take it. You'll take it. Very different. So anybody who uses free market and hospital care in the same sentence needs to come and talk to me. Okay? So what this does is it says to insurance companies, you can't base a premium based on the length of time you're enrolled, the member is enrolled in a plan. You may not charge women more than men, which fellas they do today. You may not charge a higher premium to an individual with a pre-existing condition. You may not charge an individual more who works at Eastern Iron Works and might be more likely to get hurt, or like my son who happens to do extreme snowboarding. Boy, if you don't think I want coverage for him. But they can't charge him more than a person who sits at a desk all day. So these are new rules with the Affordable Care Act. There will be some pricing bands allowed for age, some differential for age, and smokers. Insurance companies can charge smokers 1.5% more than non-smokers. It doesn't seem like a lot to me, but they can do that. 1.5, I'm sorry, 1.5 times more. There will also be an allowance for geography. I'm sure that most of you read the New York Times article, or at least heard about it, about the variance in hospital charges for the same procedure, region to region. Insurers will be able to charge more in San Diego than they do in Charlotte because of that, because there is that variance in costs and charges.
The New York Times also said how difficult it is now to compare the prices because of the hospitals. Probably not Charlotte. You cannot tell what the price is. They don't give you an itemized bill.
Yeah.
Will Obamacare address that?
Not yet. Now, what they're pressing for is price transparency. But I can tell you, quite honestly, and I've got staff here who I hope will back me up, there is no rhyme or reason to it. It's very difficult to justify what is charged on a hospital by hospital basis. And part of the reason is nobody pays us what we charge. That's part of the reason. The other part of the reason is, as an industry, we are incented to charge more. And here's why I say that. If Blue Cross comes to me, remember that toaster? Toaster that costs $1, or I charge $1 for? And if Blue Cross comes to me and says to me, I will pay you 95% of whatever your charges are, what's going to happen to my charges?
Going to go down.
Anybody? No. They're going to go up. They're going to go up. Because if it's 95% of $1, that's good. But if it's 95% of $1.50, that's even better. So the incentives in the healthcare system are, at the very least, screwed up. The Affordable Care Act does attempt to take us down a path where we make more sense of it, longer term. It's a huge challenge. Now, I will also say that in Southern California, part of the reason the charges might be more is they are paying more for labor than we do in Charlevoix. They probably are paying more for the buildings, expenses of maintaining those buildings. So there might be a slight adjustment that is called for. Now, should a total hip cost $17,300, which is what we charge, I think, in Charlevoix, and $24,000 at McLaren? I don't know, but that's what it is.
I'd also like to say there's a
Yes.
limit on how much you can increase the price.
Yes, right, that's true, yeah. Blue Cross got smart. And the other insurers did get smart because in the good old days, they were being hit with some pretty steep increases in charges. So they do tell us, next year you can only raise your charges 2.2%, yeah. So they are trying to cap that. Good point, thank you, yes.
Question on the prices, based on those purport things. If I'm an insurance company and I have to cover everybody for those things, wouldn't all the insurance premiums go up?
Well, that's what the common wisdom would tell you. What we're seeing on the exchanges is that not quite happening. It's not happening. As I use those 3 states, and the 4th being Massachusetts, they actually saw premiums come down. I haven't seen any numbers in Michigan yet. Have you guys? No. So we haven't really seen what the premium rates are going to be yet. We hope to be able to see those next month. Okay, we're going to learn more. This you have is a handout. There are all kinds of websites where you can get more information. You signed a sign-up sheet back there because our hospital is going to be going through a process where many of our team members will become what's called a certified application counselor. So we want to support people who are going through the difficult process of going through the exchanges and signing up for health insurance. In addition, there are navigators that are going to be trained at the Public Health Department, at the East Jordan Family Health Center, and other rural centers around northern Michigan who will be trained to help. And as soon as we have all of those numbers, which we don't have right now, if you leave us your email, we'll send them to you so that you can get additional information. What have I missed? Yeah.
Well, now I have a question back to
Sure.
the bus. I'll change it to
Now
the
you're all worried
guy.
about getting hit by that bus.
Change it to the guy who just doesn't believe in motorcycle helmets.
Oh, boy.
And now he's a vegetable. He's certainly going to exhaust whatever assets he has very quickly. Who's going to pick up the tab?
Most of that will be picked up by the hospitals.
By the hospital. The Affordable Health Care Act has nothing to do with that.
Nothing. That's the way it works today.
So
And our
the only
hospital,
way the hospital can stay in business, if it has enough of those, is to somewhere upcharge somewhere. Either that or go bankrupt.
well, again, there's something that a hospital has called a payer mix, which describes how people pay for the coverage that they get. In our particular case, it's around 45% Medicare. That means that 45% of our revenue comes from Medicare. Another 12% from Medicaid, it varies on a monthly basis. About 7% comes from commercial insurers, and then about 23 to 26% in that range is going to come from Blue Cross Blue Shield. 7% uninsured, private pay, sounds about right. We write off anywhere from $1.5 million, $1.7 million, $2 million a year. And that's like saying to a business, remember those toasters? You got to just give away the first 10%. You're just going to give away those toasters. So that's what happens. And that's what happens, not just our hospital, hospitals across the country.
Is that going to change under ACA?
Probably not. Probably not. There will still be people who get the $5,000 deductible plan. And what that means is it's quite possible that the hospital, if it's a hospital, might never see that $5,000 coming from the individual.
You could live with
Because-
5,000, but not what it would cost.
Forever and ever, right?
That, it sounds to me like that you continue to eat.
Yeah. And,
Ouch.
yeah, it is ouch. It is absolutely ouch. And it's, again, people always, they look at a hospital in a community like ours. Our facilities are well kept. We've got 360 fabulous employees. We've got 45 terrific doctors. And by all means and measures, we look like a really thriving, successful business. Except, it's hard to make a buck in healthcare. And it's why philanthropy is so important to us as a nonprofit organization, to help us keep up our facilities and equipment that otherwise we wouldn't be able to afford to purchase. So that's, again, a very important thing that nonprofit hospitals have. I was headed down somewhere with that toaster thing and I forgot.
I was gonna mention auto insurance. for
Yeah.
The bus and the motorcycle.
Yeah, that's right. That's right, because auto insurance does kick in. Again, unless they change that no fault law, which,
So is that where the catastrophic, we pay, when we get auto insurance, we pay lots of bucks
yeah.
for each vehicle for catastrophic
And part of-
coverage.
yeah,
Does that
part of
go
that is-
to the
yes.
hospital? Should that guy without a helmet spill his brains?
That guy without a helmet probably doesn't have insurance today either. By the way.
So it's the
Right.
no, it's
It's the no fault.
It's me paying $300 for my little toy motorcycle, when in fact I'm never gonna hurt anybody with it. But that's where the money's going. I didn't make that connection.
Yeah. I think the other thing that we have to decide as a society, it's very easy to compare us with Canada, with Great Britain, with Germany, with France, with Japan, Norway, all of these civilized countries that have a universal healthcare system. Their people grew up with that system. We have grown up with something very different, and we have much higher expectations of our healthcare system. And we have yet, as a country, to define or decide whether healthcare is an entitlement or that toaster. So as a hospital, we're operating somewhere in the gray, somewhere in between. And that's what makes it very, very difficult to operate. Whatever, you had a question?
Well, is that where some of the judgment or morality calls are gonna come in? Where someone doesn't have adequate coverage
No?
or they're elderly, you know, we want to talk about that.
Can you
No.
repeat?
No.
Because, you know, they're not going to do all of the testing and, I mean, I guess it's gonna be up to the individual hospital, doctor, whatever.
No, never, no. And I will say this is the whole question of the death panel discussion. It's the whole question of whether dollars will ultimately define ethics for the healthcare system. I can tell you that there are, in my hospital, and I've worked in a lot of hospitals, there are no doctors and certainly no healthcare administrators are making pull-the-plug decisions, and certainly not based on economics. Not happening today and won't happen post-Affordable Care Act. Those are family decisions. That's why if you've ever heard of the 5 wishes, if you don't have one, please fill one out. And what that does is it allows you and your family to decide what you want to happen if you get hit by that bus, if you're terminally ill, if you do or do not want to have your life prolonged by extraordinary methods. That's where the decision factor is. We would be a sad society indeed if we ceded that responsibility to our doctors and hospitals and made those decisions based on economics. We would never want to.
Also, when you were talking back before, you said that federal government will pick up, let's make up a number, 1 million more people on Medicaid.
Mhm.
And the federal government will pick up that amount. Well, where do you think the money is going to come from?
Well, some of it, and
I can't
again,
quite hear what she said.
I'm sorry, what you asked for is where's the money going to come from? I have another slide presentation that goes into great detail about how the Affordable Care Act is funded. There are certain increases in taxes that are going to pay for it. There are certain increases in certain levies on medical equipment. There are built-in reductions in payment to hospitals and physicians that contribute to that. So there are ways built into the law that cover the expansion. Again, go ahead.
We're paying for it anyway.
Yeah.
You're paying for it anyway.
Yeah.
What did she just say? They write off 1.5 million a year? That comes from somewhere. So either you get them on the books, subsidized Medicaid, or you pay through it like my $300 to the uninsured motorist for my little bicycle motorcycle thing.
Society is paying one
But
way or
somebody's
the other.
paying.
Yeah. We're paying today, we'll be paying in a different way tomorrow. And I think, again, as a country, part of it is a morality issue. You know, we spend more money killing people than we do insuring people and giving them good health care. Is that where we want to be as a country? I don't know. I don't want to come down on that side. But we have to make those decisions. Did you have Ted, did you have another question?
No,
Or
I
just
just-
wanted to hear, okay, good, yeah.
These hubs, the repository of all this digital information.
Like the health information exchanges,
No, actually medical information on people.
that's what they are, the health information exchanges. What she's talking about is part of the Affordable Care Act provides incentives to hospitals and physicians to implement what's called the electronic health record. Now, what that means is that we, as an industry, are investing a lot of money to make care better for the patient. And this is why I say that. If you are a patient, and many patients in northern Michigan have a home here, and then they go somewhere else in the wintertime. So if you're going to get care that's somewhere else in the wintertime, somewhere else, it's very difficult for you to be able to transport easily all of your medical records, all of your x-ray films, all of the tests that you just had at Charlotte Area Hospital down to your place in Scottsdale. With electronic health records and through statewide health information exchanges, we will be able to have an electronic record that is transportable, that your physician in Florida will be able to pull up on his or her screen and see exactly what has happened to you and see the results in the last 6 months, so they don't have to repeat tests. We don't have to do more to you because we understand it's already been done.
What about the security of such a system?
That's, again, they're working on it right now, and what they're working on is making it as secure as possible. There is an existing example of a system that works exceedingly well. It is called Cancer Treatment Centers of America. They have 5 centers nationwide, all connected via their health information network, okay? You can, if you are a patient, or if you have been given permission by that patient, you can access those medical records any time of the day or night, right online, right in the comfort of your own home. You know what tests were run, you know when they were run, you know what the results were, and by the way, you know what your appointment is in the next 6 weeks. Now, again, security, big issue. With all of our HIPAA regulations that hospitals are required to comply with, privacy is a big issue. We don't want that information just floating out there. But I'm fairly confident that we'll be able to handle that well. So that you, the patient, control access.
I'm worried about the hackers, not you.
Oh, yeah. You're worried about what? Hackers.
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 That
Yeah.
means all of your information, social security, if you give them a credit card to pay the bill, it's all there.
It's already
Well,
true.
some of those
It's
will be
already
encoded, and you might only have the last 4 digits of your,
Well,
well,
if you know about hackers.
I know.
See you later.
I worked at Dura in East Jordan. They were there for 4 years. Anyway, I worked there for 29 years, and I was financial secretary part of the time. We had to be bonded. The union said we had to be bonded. In other words, insured to be trained and to be responsible for social security numbers, among lots of other stuff. Nowadays, there's all kinds of people that have social security numbers. They're not bonded at all. It's just, it's sort of throwing cards around. I mean, employers, job applications, those people are bonded. All kinds of people should be armed. And
Yeah.
what do you do? Lie detector test or something?
I'm not even sure that would help. But I have to tell you that the restrictions on hospitals are significant and the penalties are severe for tripping a target or for letting health information related to an individual patient get loose. You had it, I'm sorry.
Recently, my son had to visit the emergency room, and...
Oh, don't tell me it went badly.
No, it was good. It was minor.
This is good.
But anyway, my wife made a comment that the doctors seem to take a lot of time entering information into the record and seems to bog down the system, at least for the professionals. Is there any way to streamline that, or is that something that's going to be better or worse, or?
I tend to be an optimist. It's going to get better. This is relatively new to us. And put yourself in the position of a physician who might be 60 or 65 years old. Hey, this is tough stuff. And so even for somebody like Kat, who was weaned on a computer, Learning the electronic health record process is not an easy thing. Will it get better? Absolutely it will. Absolutely it will. But it's going to be slow for a while.
The secretary was found a doctor.
I know. Believe me,
I'm just curious.
if we could afford it, I would have a scribe for all of our doctors over the age of 60 that just go behind them and enter stuff. We just can't afford it. So, yeah.
I was just worrying about the information, your healthcare information being disclosed. Two things. One, I guess the one that would worry me most is insurance companies because they'd raise your rates, but they can't do that now. And I had dinner with a gal the other day that sent out your MasterCard applications, you know, that you get in the mail, like, get a new Visa. And she said, we know everything about you. Every time you use a rewards card, we know what you bought, we know how much you paid, we know your income, we know, I mean, that cat is out of the box.
Yes.
I mean, and that's companies that are for-profit, trying to get you to take out a new Visa.
Now, again.
That's why rewards cards exist.
Yeah.
When you sign up and you get that little discount, it tells everybody
Yeah.
what you buy.
Yeah.
Everybody.
Yeah.
That is not,
You're gonna get 10 cents off.
yeah. You get 10 cents off, but everybody.
I will tell you this, hospitals must take privacy very seriously. We have a 4 or 5 page document that says this is what we must do on your behalf to protect your information. We take that very seriously at our hospital. Not only is it the right thing to do, but we face some really serious fines in the hundreds of thousands of dollars if we betray that trust. So that's not a place we want to go as an industry or as an individual hospital, for sure. It is exactly 6:30. Nice job, you guys. Yeah,
I'm sorry, I know you can introduce yourself.